Now, after seeing all the surgical videos, now I'll be talking about the cellular level, and there was a lot of boom and wow regarding the Dugas layer recently in last 2-3 years. So, and nobody knows exactly what is the implication of Dugas layers in understanding the dark surgery. So we thought of actually discussing about this. So it's over a decade now that people are performing dark surgeries with the big bubble technique, but there were a number of clues why this big bubble used to get restricted at the 9 millimeter of the cornea, and there used to be a white ring around that, and it led to the investigations, and it characterized the invention of the Dugas layer. Basically, it's a well-defined, acellular, strong, resilient, and flexible layer which is located just in front of the Descemet's membrane, and it had helped a lot to the dark surgeons for the better understanding of the lamellar corneal procedures and also few posterior corneal pathologies. So coming to the characteristics of the Dugas layer, it's basically a collagen layer with a long spacing collagens, and you also see these collagens arranged in a parallel fashion, and there are few strands which run across the Dugas layer to the posterior stroma, and these are known as the bridging collagen fibrils. The mean thickness of the Dugas layer is around 10 to plus minus 3 microns. So this is the histological picture where you can see many bubbles in the posterior corneal stroma. After these bubble coalesces and goes into the between the Dugas layer and the posterior stromal layer and forms a big bubble. In this particular picture, we have removed in this histological picture the Descemet membrane layer is removed, and what you can see after the bubble is the fine Dugas layer. All these findings were also confirmed with the scanning electron microscopy, where it showed that the anterior surface of the Dugas layer was grossly rough compared to the posterior surface, which was very smooth. And you can also see many collagen fibrils, crisscross collagen fibrils, and the long spacing for collagen fibrils in the Dugas layer. So now we'll be discussing how this knowledge, or probably this knowledge of the Dugas layer, can be utilized to understand the clinical relevance and the application of this discovery of this Dugas layer. As we all know, we have seen the type 1 big bubble, where it is usually restricted around to the 8 to 9 millimeters of the cornea, and you also see a typical white ring around this big bubble. So why this has happened? So when histologically it was studied, the Dugas layers ends at the 9 millimeter of the posterior corneal layer, and there are the bridging collagen fibrils which connects the posterior corneal stroma to the Dugas layer. And when you actually push the air inside this layer, there is a stretching of this bridging fibrils and leads to a white ring, which is seen clinically. This is another microscopic picture where you can see the Descemet membrane has been torn, and you can still see the big bubble being retained, and that is the Dugas layer which is retaining the big bubble. In the diagram B, you can also see when the surgeons were pulling the Dugas layer, you can see the stretch marks reaching up to the 9 millimeter of the peripheral cornea. The another bubble is the type 2 bubble, where the air escapes between the Dugas layer and the Descemet membrane layer. These bubbles are usually very large, reaching up to the limbus, one end of the limbus to the other limbus, and when you dissect the anterior stroma ahead of this bubble, you'll see a very smooth bed, which indicates probably it's a Descemet's membrane rather than the Dugas layer. The importance or the implications of identifying type 1 and type 2 because of the identification of the Dugas layer is that in type 2 bubbles you have to be more careful because it's a thinner and a bigger bubble, so you have to be very careful while making paracentesis or doing a debulking of the stroma. The another bubble is the double bubble, which is a mixed type of bubble in which you get both the types of bubble coexist, where the type 1 bubble is a large bubble and the type 2 bubble is a central small bubble. So these are the three various types of bubble you can see. And the first is the type 1, which is restricted to the 9 millimeter. The second is reaching up to from limbus to limbus, and the third which is showing both the two bubbles existing at the same time. So as I already said, why we want to know this, whether it is a type 1 or the type 2, is because if you know that you are dealing with a type 2 bubble, then you have to be more careful, because here is the bubble is probably very large and very thin, so there is a higher chance of DM tear or the ruptures. But when you know it's a type 1 bubble, even if you find a small rupture or the tear in the Duas layer, you can always go ahead with the DALK procedure. Rather, in case of a DM tear, you can definitely shouldn't be going ahead with the DALK procedure, because there are higher chances of this tear being extending, and you have to convert your DALK to the penetrating keratoplasty. There is also an evidence in many studies that they have shown the patients who have undergone DALK are lesser susceptible to rupture in comparison to penetrating keratoplasty. This study was indicating that probably it is because of the retained Duas layer in the patients of who have undergone DALK surgery with the big bubble technique, where they have achieved a type 1 bubble. There are also studies where people have seen in patients where previous clear corneal surgeries have been attempted, like a penetrating keratoplasty or phacoemulsification, where because of the clear corneal incisions, there was a breach in the Duas layer leading to escape of the air, leading to failure of the formation of the big bubble and difficulties in doing the DALK procedure. As Dr. Bakshi has already said, the macular dystrophy involves most of the layers of the cornea, but still in cases where it is not involved in the endothelium and you suspect that the endothelium is doing good, you can always go ahead in these cases with the type 2 bubble technique and do the DALK procedure successfully. There is a surgeon who has also studied and has shown there is a lack of keratocytes in the Duas layer, and which was also studied and seen in the cases of post-infectious scarring or in cases of post-trauma, where after removing the anterostroma, the Duas layer was not involved. So here in these cases also, we can perform a type 1 big bubble and achieve a good outcomes after the DALK surgery. The invention of Duas layer has also helped us to understand many posterior corneal pathologies, wherein keratoconus, we used to think that the acute head drops is basically because of the dehiscence in the descemet membrane, but practically later on electron microscopy study, it was because of the tear and dehiscence of the Duas layer leading to the corneal stromal hydration. In descemetocele also they have shown. Previously, people used to think that this descemetocele is probably not rupturing or not perforating because of the strong descemet membrane layer, but practically later it was shown that it was because of the presence of the Duas layer. There are surgeons, after studying the strength of the Duas layer, who have also attempted performing triple procedures along with the DALK. That was only possible because we came to know the knowledge, we came to know the strength and the resilience and the flexibility of the Duas layer, and people performed, actually debulked the anterior cornea, and then they went ahead with the phacoemulsification followed by the DALK procedures. It again re-emphasizes on the how strong is the Duas layer. There are few studies where they have also shown there is a relation of the Duas layers along with the trabecular meshwork, where they can see there are collagen fibrils and bands running right from the Duas layers to the trabecular meshwork and attaching over the ciliary body. So they have shown that there was an association between DALK and PK, where they showed the patients who have undergone DALK has a lesser chances of glaucoma progression or lesser chances of glaucoma damage after DALK surgery compared to the penetrating keratoplasty. Thank you.